All right, welcome back. You're at the end of your second week, and this is financing and payments. And so you're at the halfway mark. I got Rafat to help me this evening, and hopefully we'll be quick and make this one short and sweet and move on and take it from there. So the power of three words for the financing section are fiscal capacity, risk pooling, resource allocation, and then rationing. The last chapter we're going to cover tonight, or for today, whenever you're watching this particular video, is on payment. The power of three words for the payment section is fee for service, capitation, global budget, and line item budget. And if you listen carefully, we'll probably go over all four of those in great detail on that section. Look at this. We're back to the knobs that Dr. Saloom talked about on the first section. Rafat, you want to say something about the knobs?
Yeah, these control knobs are important regulator for health sector reform, and you can remember this financing, payment, organization, and behavior. Those are important aspects of health sector reform. That's why it is called knobs, and these are important regulatory aspects of health sector reform.
All right, so if we start off with some of the basic questions when it comes to financing, you have to determine how much money is available, who's going to bear the financial burden, who's responsible, who controls the funds, how risks are pooled, and whether healthcare costs can be controlled. So you start out asking some questions, finding out who's responsible, and then take it from there.
Health sector funds can come directly or indirectly from citizens.
You mean like the tax man, Rafat?
Yes, like taxman. Like 60s Beatles taxman. Tax is an indirect method because citizen pays tax for various purposes. Government can use those taxes for many more purposes, but they can use some direct method like citizen payroll tax deduction for Medicare, and after deciding on the sources and to what extent they are using this money for the health sector, the government has to allocate this money for financing of healthcare through some method.
What kind of method, Rafat? The squeaking wheel gets greased method?
No, Rick. These are all proven, tested economic method. So apart from this general revenue, that is tax, there are many more methods like social insurance, private insurance, direct payment is out-of-pocket payment of patients, and community financing. So what is social insurance? Social insurance is one kind of mandatory insurance that is governed by the government itself. And like Germany implemented the social insurance in 1883 under the presidency or chancellorship of Bismarck, and so in that method, workers and employers paid some portion for the healthcare sector, and all of the citizens are compelled to be there under the scheme. In private insurance, there is no compelling factor. There is voluntary, and people can choose their own insurance and be insured. And so, if they like USA, you can be uninsured and be uninsured, or may buy a very high premium plan. And always there is the option of payments out of their pocket. And in our country, in USA, there is a predominant method of payment.
Don't forget community financing, especially in the poor rural communities. They only have limited capacity to raise funds for healthcare, but it's important in their funding for primary healthcare services. So let's continue on. All right, so the key points to take away, obviously, the first two are pretty intuitive. If you don't have the funding, you're not going to have it. Low-income countries, most of their expenses are going to be out of pocket.
Right. For middle-income countries, they are more inclined to social insurance, and they opted for universal health coverage. But given their economy and economic strength, they are more for social insurance out of pocket or out of the pay tax deduction from the employers and employees. And for high income countries, they can afford the universal access to healthcare, and there's a big exception, that is US. US didn't go for this high universal health coverage after all these years because there are many reasons. But
Yeah. The AMA, et cetera, et cetera, et cetera.
For judging financial methods, there are some ballpark points. Equity is one of them. First kind of equity is vertical equity, that is equity or fairness between the different economic classes, that from rich to poor all are getting same kind of healthcare services. And horizontal equity means the same kind of services are rendered for the people within an economic group. So within low income people, they are getting all sorts of services in similar amount and similar access. And in terms of risk pooling, there is the second point is risk pooling, that plan should cover both low risk and high risk people, that a plan is not making money only covering the less prone people to sickness, or losing money because of only covering the high risk people, that is the adverse selection is not there. So for effective risk pooling, you have to have both kinds of people.
Can I give you a present day example? We had it earlier. Remember there was that one slide where we had the pool and all the sick, chronically ill people were swimming around the pool, and who wasn't jumping in the pool? Who had their little life ring on? The young 24-year-olds,
Yeah.
which is a problem in the United States right now because they're not getting into that risk pool that,
So
the
they're
Obamacare-
not willing to be in the pool. But if they are not there, so the pool is mostly the high risk people.
Mhm.
So there is no effective pooling. So Affordable Care Act is trying to address this part, because if there is effective risk pooling, then the plan should be very
Beneficial to all.
beneficial. Yes.
All right, so general revenue.
Rick, we have already gone through that general revenue part, the taxation part. And
Yeah, I see.
students can read that from the slide. And
All right, let me pick up the pace then. All right, next one is social insurance. I guess the most important characteristic, we've covered a lot of this, but make sure that you know compulsory, and that is, everyone in the eligible group must enroll and pay the specific premium, so it's covered across everybody, so it's not an option. So the opposite of that would be private insurance, which would not be compulsory, and so it's extra above and beyond where the individual purchases the plan. Yeah, the same applies here. If you look at direct payment, those are expenditures that are out of pocket for patients. So I'm sure you read that already in the PowerPoint. Community financing, we already talked about that already. So let's go on to the next slide. All right, allocation was where I was picking on Rafat, and I said squeaking wheel gets the grease, but you've got to look at the trade-offs, and as Rafat said, there are economic formulas that are used, allocation towards specific population groups, and then you may have some rationing to allocation to individuals. For example, let's look at maybe the WIC program in South Carolina and the pregnant women getting the benefit from that. So let's go on to the next slide.
So government can mobilize the fund for health sector, but besides that, social or private health insurance plans are also important part of many countries' health sector, and community financing schemes are also very important for rural poor in poor countries. And many decision has to be made which organizations are in charge and what to pay them for and how much to pay them, and so whom they are paying, that is maybe the hospital or the physicians, and how much they are paying, and what is the method of payment. So payment method is important for health sector. Here we are seeing the different payment methods for physicians and hospitals. We can see the fee for service is their predominant type of method in many countries and in many places. Salary is another type of payment that physician can be paid, the salary employee of the hospitals. Capitation is another kind of payment where a fixed amount for each and every enrollee of plan is given to the hospital or physician, and they have to take care of the enrollees every possible health illnesses. So per diem and per admission is a payment method for hospitals, where each day hospitals being reimbursed irrespective of the services, but for per admission, each admission there is a specific amount of money for the hospitals. And case mix, adjusted, these are the different type of payment method that case-based reimbursement, the DRG, diagnosis related group, covers that as one type of diagnosis will be reimbursed according to a fixed rate. And their line item budget and global budget, this budgeting system is mainly seen in the developing countries, where the government controls all the health sector, and they pay the regional health sector financing organizations the limited amount of money. They can be paid a global budget, that this is your money, you can pay out of it what type of services, you can decide your own services, but the line items can be decided from the center, and they will pay them according to a fixed amount per each line item. So these are the different payment methods for physicians and hospitals. So in this slide we can see that who is bearing the risk for payment, and what are the incentives for the provider to increase or decrease services. So fee for service, all risks are borne by the payer. You can see that in case of capitation, the providers only bear the whole risk, and in where their bonus is related to their performance, their bonus portion is related to their risk. So these two types of payment method, provider bears the risk, and for FFS and salary, payers are the risk bearer. And we can logically think that for capitation, providers' incentive is to decrease the amount of services, and for salary or for fee for services, where each and every services is being reimbursed, the provider has the perverse incentive of treating more and prescribing more. Reach the beast.
All right, so let me look at this one. Same chart that Rafat just went over. This one is for hospitals, but what's overlooked is when we talk about fee for service, that's kind of what put the United States in such bad shape, is that there's no incentive to control costs. You just want to bill, and no one gets between the doctor and its patient. So the other thing that the government tried to do is use DRGs, which is a way to kind of control costs, that when you have a certain operation, you only get paid a certain amount. And so what do you got? Per diem, capitation, there's another control mechanism. Global budget, that tends to be more, foreign countries, not the United States, where there's a well-established budget. You got anything else you want to add on this particular slide? And the other thing I said at the end, what I did is I put a nice summary for you guys that I think is a good way to study for this particular material.
Right, you can go through the slide, final few slides, and you can see that there advantages, disadvantages, and what are the incentives for the providers for more services or less services. So you can come up with the summary, and you can decide which payment method can be good for US health system, or you, in your mind, what do you think, which payment system will work well.
So the next two slides are nice summaries. This one has the payment mechanism and then the impact, and then kind of an overview of all the plans and kind of the pluses and minuses, or advantages and disadvantages. So that's it. I mean, this is kind of one of those things that you just need to memorize each one of the payment mechanisms and know how to apply it accordingly.
Right, you have to think about it. All those payment methods has its own advantages and disadvantages. So it is difficult to say that this is superior to that one, but one policy maker has to come up with the ideal, prudent, that is fit to the situation method for payment for the hospital and providers.
Right, and it's not just specific to the United States. You got to think globally when you look at these issues.
Right.